Morning, everybody. This is just an introduction to the new 2021 curriculum. So this is going to be brought in from August of this year. There's been some delays with it because of problems with GMC and HEE approval for the curriculum, and actually it still hasn't been approved by the GMC, but the idea is that it is going to be brought in from August. It was meant to be August 20, but obviously a few things got in the way with that. So we've done a couple of meetings this week already for college tutors and supervisors, so some of you may have been in those meetings and heard some of this already. I appreciate some of you won't have known very much about the curriculum at all. There's quite a lot of information in all of this, very aware of that. So Rob's obviously recording this, and we've recorded our meetings that we did earlier this week as well. And also, you know, obviously anybody's welcome to have the slides too. So myself and Nikki Hickman are the regional leads for the introduction of the curriculum. And so please feel free, you know, after this or at any point between now and August to get in touch with either of us if you've got any questions. So what I'm going to do is go through some of the reasons for change. We're going to go through the new structure, and we're going to go through a bit of how it's going to be assessed. So why change? Well, the GMC brought out this document in 2017, Excellence by Design, and basically they mandated that all curricula had to be revised by August 2020. So this is the medics, the surgeons, peds, everybody has had to revise their curriculum. And it's basically to take into account generic professional capabilities, and they want much more emphasis on those things. And those things like teamwork, safeguarding, education, training, that kind of thing. They want a much smaller number of specialty learning outcomes, so sort of kind of focused clinical things. They want a very much broader portfolio, if you like, and a much reduced assessment burden for the trainees. So, and this came on the background of the Shape of Training review by Greenaway in 2014, and basically this was to do with the challenges of the population changing and what we need to do to move with that. This suggested that we should all be able to have the skills to manage an unselected emergency workload. We should have flexible training, and maybe there should be some areas to get credentials in post-CCT, for example, pain or pre-hospital medicine or sleep, that kind of thing. Broad-based training. As well as this, the introduction of the curriculum has really been an opportunity to act on some kind of findings from various morale surveys about exam timing and assessment burden. In the old curriculum, there was quite a few consistencies in terms of opportunity for higher and advanced training, and so hopefully we're going to address some of those and think a bit about the way that we assess the trainees too. And this report from the college in 2017 was quite sobering, really. So looking at what the pressures are faced by the trainees, they were feeling a lot of pressure to try and pass the primary within 2 years of core training, and many people didn't. And also they wanted the opportunity to get much more clinical experience before starting as a registrar in ST3. And when we look at our own and national data, around 20% of the ARCP outcomes for the core trainees are not standard. Now, at CT1, almost nobody gets a non-standard outcome. Everybody gets an outcome one pretty much as long as everything's been reasonably okay. So this kind of translates into a lot of the CT2 trainees, so about 40% of CT2 trainees not completing all the requirements of core training in the allotted time. Most of this being exam related. So that kind of suggests that there's probably something a little bit wrong with the way that the programme and the curriculum is structured. So what are we going to change to? Well, core, intermediate, higher and advanced are going, and in we've got stage 1, stage 2 and stage 3, and stage 3 will include some special interest areas. So how does it differ? Well, if we look at stage 1 versus what is currently core, key change is that this now lasts for 3 years rather than 2 years, and if trainees are on an ACCS programme, then obviously 4 rather than 3. So there's an extra year in stage 1. And this really takes account of that extra year that most people are taking to pass the primary. So currently a lot of people are going out of training, going to do a trust post and taking that time to pass the primary. And the aim is to keep them in training. The kind of capabilities of what people are meant to be able to do in this CT3 year are pretty similar to what we expect of them in ST3. But key things are an increased exposure to perioperative medicine, increased competence with TIVA, more exposure to kids over 5, and crucially being able to be first on call for obstetrics. And that's something that isn't mandated in the current curriculum. Also in stage 1, trainees are going to have to do 6 months of ICM in comparison to the 3 months that they do currently. Stage 2, not too much different. So this is what equates to the old ST4-5 kind of stage. So again, more perioperative medicine, but again, crucially here, they only do 1 block of neuro and 1 block of cardiothoracics rather than 2. So rather than doing intermediate neuro and higher neuro, you will just do 1 block of each of those things. The specialist peds exposure happens at this time, and more TIVA, lots of emphasis on TIVA, and a bit more regional anaesthesia and use of ultrasound for a wide variety of blocks. And then they need to pass the final by the end of ST5, so before leaving stage 2. And then with stage 3, this is what the old higher or advanced training would be, so ST6 and 7. So no further mandatory neurocardiothoracics, although we can visit these as specialist interest areas that I'll talk about in a bit. No more ICU, crucially. There are some things that relate to critical care management, but there is no requirement to do another 3-month ICU block at this stage. Everyone needs to do more obstetrics. In the current curriculum, obstetrics isn't mandatory, although we've usually strongly encouraged people to do it. Now everybody has to do it. And a real significant change is that everybody needs to do pain at stage 1, stage 2 and stage 3. We've had a few issues with delivery of pain around the region. So this is going to have to be something that we really try and work on, but this is a big change. And then advanced training is replaced by some special interest areas, and they kind of suggest that people do either 6 to 12 months in some of the larger specialties or 3 to 6 months in some of the other ones, and perhaps combine 2 or 3 of these. And then a really significant thing, going back to what that GMC report was all about really, is these professional domains. So already in Annex A of the existing curriculum, they have to show evidence of all these non-clinical things like teamwork and communication and stuff. But much more emphasis is going to be placed on all of this, as well as formal assessment and formal kind of training in QI methodology. Child protection gets a big emphasis, simulation training has more emphasis, and also research governance and critical literature appraisal. So all of these things happen at all stages of the curriculum. So there'll be some service implications for all of this. So the content of the CCT programme is pretty much the same. So we're not going to have to all of a sudden train people in stuff that we weren't training them in before. But the post numbers are a bit different. So there's going to be approximately 600 CT3 people across the country versus the 450 ST3 posts and people that we have at the moment. So locally, we've been asking trusts to provide extra posts that we can transition people into their stage 3 years. We're going to have to provide the opportunity for trainees to do obstetric on call in stage 1. Not so much of an issue in NUH, but certainly an issue in some of the DGHs where trainees don't currently do obstetric on call at that stage. We have to provide 6 months of ICM in stage 1, 3 months in stage 2, and not necessarily any in stage 3. So that will affect the ICU rotas. As I said, just the 1 block of neuro and cardiothoracics in stage 2. So we need to make sure they've got their capabilities by the end of that, because there's no coming back after they've done it. Specialist peds in stage 2. Whereas stage 3 focuses on the sick child in a DGH really. And then in stage 3, it's more about the breadth of activity and getting this broad-based training that has been recommended and is required. So the transition to this, it's all going to be pretty soon, really. So people are going to start transitioning from August 2021, so this August, and everybody has to be transitioned by August 2023, with pretty much no exceptions, apart from maybe if your CCT happens to be in September or October 2023, then that would be pragmatic not to do that. But by and large, they want everybody onto this by August 23. So quite easy for those who are CT1, they'll start on the new curriculum, or CT2, they will be transitioned onto it in August. For the people that are starting ST3 in August, they will just start the new curriculum, and they will need to top up potentially in ST3 to complete what would have been their stage 1 training in the new curriculum. Stage 4, they will start on the new ST4, start on the new curriculum and start stage 2. ST5 will go on and top up to complete stage 2. ST6 and 7 should stay on the old if they're going to finish by August 2023. So people that won't be able to do this are those that are on OOP, so there may be ST6, but their CCT won't fall before August 23, and those trainees who are less than full-time, who's maybe in ST6, for example, but won't finish by this date. And all those people are going to need some individual plans of when they transition. But the feeling is probably sooner rather than later to make it simpler. The problem is that some trainees will fall into a gap in between CT2 and ST4. So significantly, ST3 recruitment, so the old ST3 recruitment stops for the February 22 intake. So we've got an intake this August, we've got an intake in February, and then that is it. And anybody that hasn't got an ST3 post by that point is kind of falling into this gap, because there's no ST4 recruitment, which, if you remember, is the start of stage 2, until August 2023. So there's a real big gap where trainees are not going to be able to get onto a training scheme. So, and the college figures are about, 50% of people won't get this. And so we need to be able to look after these trainees and ensure that they can get the capabilities that they need to bridge this gap between the end of their old core training and where they need to be at the start of their new stage 2. So effectively get a stage 1 sign off before they can start to apply, and they're going to be in this time period. This is what they're going to be doing. And so departments are going to be asked to provide training in more ICM, obstetric on call, so that they can fulfil that capability, and all the other things that they need for a stage 1 sign off. And there's pretty good gap analysis of that on the college website for any trainees that want to look at that and think that that might apply to them. And then this is all going to need proper sign off then to allow them to apply at ST4 for stage 2 training. So how's all this going to be assessed? Well, there's a real focus on the assessments being assessments for learning, so formative assessments rather than more summative assessments, although they do still exist. They really want to avoid the kind of tick box thing of, yeah, I can do that, I can do that, I can do that, but what does that actually mean? They want to emphasise supervision levels and enable trainees to show what supervision level they need for certain tasks. And to do this, have supervised learning events to provide information on trainee progression. And then all this will inform how likely it is the trainee is going to progress at the critical progression points between the stages of training, stage 1, stage 2, stage 3, and also at the IAC and IAC-OA stages. And the idea is that any assessments that are done can be mapped across lots and lots of capabilities, and so the assessment burden should not be any greater, and hopefully it should be less. So we've got some new terminology and new abbreviations. obviously, because it's a new curriculum. So we'll go through what some of these are, and I know it's a lot to take in, but you will, as you hear this more and more, it'll become more familiar. So we are assessing three stages of training, and there's 14 domains in each stage of training, and at each one it's the same 14, but you just do them at greater depth each time. So just revisit round and round and round. And these are made up of these general professional things, teamwork, QI, that kind of thing, and then all the specific clinical things. And as I said, we have a mixture of formative and summative assessments for them. And so these are the 14 domains that we need to be looking at and assessing. So the top 7 are these general professional capabilities. So professional behaviours, communication, management of professional and regulatory requirements, teamwork, safety QI, safeguarding, education and research. So that is, half of what needs to be done. And then underneath we've got the clinical domains, and there are 7 of those as well. So 2 big ones, perioperative medicine, health promotion, and the whole of general anaesthesia. And then 5 smaller ones, regional anaesthesia, resuscitation, transfer, sedation, pain, and intensive care. So at each stage of training, trainees have to evidence stuff for each of these 14 domains. So supervised learning events, referred to these earlier. So these are just the old workplace-based assessments. So KEXs, DOPs, CBDs, all these things that we've been used to filling in for a long time. Change this time, though, is that there isn't a set minimum requirement. So currently, people need to have a minimum of 3, don't they, to get whatever module it is signed off. So there's no set requirement for that now, and no minimum number. A trainee might be able to demonstrate very nicely with just 1 that they can do whatever it is you're assessing, or you may feel that they need to do that several times. These are all completed by the same types of people that they are at the moment. So designated trainers, clinical supervisors, educational supervisors, senior trainees can still do them. So no changes. There is a bit more detail in terms of the supervision level. Same interface though with the lifelong learning platform, so we should be able to access them, fill them in and everything in exactly the same way. So we mentioned the supervisory scales that they want us to focus on, and this is something that is kind of going to be brought in for every single bit of clinical practice. So it goes from 1 to 4. So 1 is direct supervisor involvement. So this is perhaps what you'd have with a new novice. You're going to be in theatre all the time. You're not going to leave them. Moving through to perhaps a 2B, where you might feel comfortable that you can be somewhere in the hospital and you can, get back to the trainee quite quickly should you need, but you're happy for them to get on. Or level 4, where we expect trainees to be at the end of their training, so you can pretty much manage independently. Obviously, you might need to phone up just to say, I'm doing this, but you're competent to get on without any specific supervision. And the idea of this is that we can assess the trainees' level of autonomy and how responsible they can be for some of these activities. And the supervision level is a bit more explicit. And it also helps to pick up some trainees who are not perhaps progressing as well as their peers. And the way that it's done is that you perhaps observe somebody doing a skill, for example, doing a block, and you decide what supervision level they would need the next time they did that. So if they were to do that immediately, or if they were to do that again that afternoon, what level of supervision would you be happy with? So although you might have directly supervised them at the time, and they've done a fantastic, popliteal nerve block or whatever, then you can say, well, I'm really happy for you to do that with me in the coffee room. So you would assess them as level 2A, or that's absolutely fine, and you might assess them as a level 3, and you can be somewhere more distant. So it's not what you're assessing them as when you're in the room there, it's what you would do next time they come to do it. And this is what the assessment forms are going to be like. So this is just an example of an ACEX, so not too much different really in terms of what's going to be captured. You're going to describe what you've done. You're going to there's going to be a bit of space for discussion about, you know, what went well or what you might have changed or whatever. And then importantly, these supervision scales down here, what level of supervision would they require if they were to do this again? And then any suggestions for the development at the bottom. So for those of you who look after novices and also trainees doing obstetrics, there are some changes with this. So for the IAC, there's no longer going to be 19 compulsory assessments to wade through. And instead, what they're going to have is the introduction of some what they call entrustable professional activities. So basically, can they do a certain skill? And I'll show you what a couple of those are in a minute. And for each of these skills, they need to achieve a set level of supervision or entrustment. So thinking back to that scale that we had a minute ago, for the IAC, this is set at a 2B, so somewhere in the hospital, and for the IACOA, it's set at a level 3. And there's also some compulsory simulation training that need to go into the provision of the IAC and the IACOA. So, and it's basically to address this, and this is something that we've all experienced, I think, that you've got a trainee who perhaps might be able to tick all the boxes in, you know, talking about muscle relaxants or pre-assessment or something, and, you know, and they've ticked all those things, but you just know full well that they can't really put it together when they're on call, and you wouldn't want them to be on call by themselves. So moving away from that, we'll still have to assess all of these things, but the actual outcome, these entrustable professional activities that they want us to do, is can this trainee anaesthetise an ASA 1 or 2 patient for uncomplicated surgery with some slightly more distant supervision? And I think that's better. To help us do all of this, the college have produced some workbooks, and you can find these on the website. So this is the one for the initial assessment of competence, the IAC, and this talks about entrustable professional activities, EPA 1 and 2. So this is all they have to do for the IAC. They have to fulfil the requirements of these. So EPA 1 is pre-assessment, EPA 2 is anaesthesia, straightforward anaesthesia of uncomplicated surgery. And this is at the level 2B, so supervisor within the hospital for queries. And then everything feeds into this, so all the assessments, simulation, observation and everything, put this together to see whether they can achieve their IAC. A similar sort of thing for obstetrics. Instead of EPAs 1 and 2, it's now 3 and 4, and that's at a supervision level 3, where the supervisor can be on call from home and doesn't need to be there for immediate attendance. Then we've got some learning outcomes. So for each of those 14 domains, we've got learning outcomes that people will need to achieve for the when they get to consultant level. So again, 7 for the generic things and 7 for the specialty specific things. And these are repeated at each of the 3 stages of training. And within those stages, there are learning outcomes for that kind of stage. So it all follows quite nicely. There are some capabilities in each stage that feed into the stage learning outcome, and then you've got the overall outcome that they need to get when they are consultant level. And importantly, and this is a really significant change, that all these kind of learning outcomes and things aren't now based on surgical specialties at all. So gone is, I don't know, core, day case or intermediate GUG or whatever. And it's replaced by, you know, have you got the abilities to manage patients who are having, I don't know, major hemorrhage, or are you okay at positioning patients? So those generic things that can be evidenced across the specialties. So if we just briefly look at this, so if we take sedation as an example, so the high level learning outcome where you should be right at the end is providing safe and effective sedation. In stage 1, the outcome is safe sedation to ASA 1 to 3 patients within the theatre complex. And underneath it gives you some examples of the capabilities they need to evidence. So can you do a pre-op assessment? Can you manage the patient's physiology appropriately? Can you look after them appropriately post-op? This moves on to stage 2. So now we're looking at safe sedation to adults and children in any hospital, in any location within the hospital. So it's a step up, less supervision, and perhaps you might be using multiple drugs, TCI things, using scoring systems and all of this. So these capabilities, they have to evidence all of these things to achieve this stage learning outcome. And then at 3, it's just delivers safe and effective procedural sedation independently. So this is pretty much what your high-level learning outcome is. And it's all patients in all settings, and you can talk about national guidelines and stuff. So that's just an example of how it kind of builds up throughout the curriculum, and this is replicated in everything. Slightly more difficult when you come to the giant domain of general anaesthesia. And these are just the outcomes for this. So stage 1, safe and effective general anaesthesia, non-complex surgery, general hospital. Stage 2, non-complex elective and emergency surgery within all settings, so perhaps some of the more complex stuff that you might see in a tertiary referral centre. And then stage 3, all patients undergoing non-specialist procedures in any hospital. And then some examples of the capabilities might be provide safe care to an adult patient with multiple injuries from arrival in hospital to post-op care and seeks help. Describe some problems related to trauma and perhaps apply some physiology and pharmacology to secondary brain injury. So instead of them being mapped to a trauma module or a neuro module, they now fulfill these kind of capabilities. And then at the end of all of this, for each of those 14 domains, they get what's called a halo form, which is pretty much analogous to the old cut form. And they need 14 of these, one for each of those stages per stage of training. And this is going to be carried out by a designated trainer. And this is what one of these is going to look like. So this is one for teamwork, and it's for stage 1. So in teamwork, in stage 1, they have to evidence these key capabilities. So describes leadership responsibilities, actively participates and contributes to the work and success of a team. So, stuff that shouldn't be too difficult to evidence. And if their supervisor's happy that that's okay, then that's that halo, one of the 14 signed off. Also going to be multiple trainer reports. So this is basically, when people email around going any feedback for such and such with a nice little photo. Instead of that, we're going to have a multiple trainer report that is going to be generated by the college tutor, sent out to people who will have had contact with that trainee, and they can feedback a bit more formally. And we need one of these at each of the critical progression points, and also at the end of things like IAC and IACOA. Minimum of 3, and it's not the MSF. MSF is staying the same. It's a different process. And that's what one of these is going to look like. So you'll have a multiple trainer report, and on the first page, it will talk about these, again, 7 generic professional capabilities, and on the page 2, about the clinical stuff. So, in, for example, regional anaesthesia, is there excellence or outstanding practice? Is it satisfactory? Are there areas for development, or can we not assess? And so this is going to be done by the assessment faculty of some designated trainers. And I would just say at this point, if you are going to be signing off any of this kind of stuff, or you've got clinical supervisory roles, just make sure that that you're registered with the GMC for that as well. So that should be on your GMC entry. You can have a look and check, and if not, it's done through the postgrad department. So if you don't think you're recognised as a trainer and you should be, then just let them know. So some designated trainers, and basically these will be the unit of training supervisors, we think. So people will be responsible for assessing these key capabilities. So perhaps whoever used to do intermediate sedation will do stage 2 sedation. It'll be more complex with the general anaesthesia domain, because there's so many things in it, and we need to come to an agreement regionally over how we're going to do this. So issues, I think there are some issues potentially with consistency between departments and between trainers, and we know that this is already a long-standing thing, and standards for unit sign-off are different around the region. So we need to be a bit careful with this. We need to be clear about who's expected to do what and make sure they're happy to do so. There's going to be an increased role for the educational supervisor in doing the sign-offs for the GPC domains, those 7 things like QI and things. And it is going to be an increased workload, and I'm aware that that may lead to some dropout because, you know, ES workload is already pretty high, and people may not feel that they want to take that on. I hope not, but it may be the case. And there is undoubtedly going to be an increased workload for the college tutors in generating these trainer reports, setting up the assessment faculties and things. So in summary, there are some challenges, some new terminology to get to grips with. It's a bit like line of duty, really. Some new roles to think about. Some, I think probably inevitably the assessment burden will increase initially, but hopefully it will decrease overall. And some real opportunities to keep some of these trainees in training, so they don't have to go off and find posts wherever. As I say, admin load hopefully decreasing, making some of these assessments a bit more meaningful and a bit less focus on, you know, ticking the box and actually can they do the job properly. So I'd point you towards the college website. It has got some really good information on it and some really good FAQs. We're all kind of starting to get to grips with it, and it is a bit of a maze, but please get in touch if you think, you know, I might be able to answer something, or Nikki might, but do have a quick look at the website as well. Okay, thank you very much.